Dr. Padmanee Sharma as our speaker today. I've had the opportunity to hear Dr. Sharma at one of the CITSI meetings a few years ago, and since then I have been planning to invite her. So thank you, Dr. Sharma, for accepting our invitation and agreeing to speak at the QCRI seminar series. Now, before I pass it on to Dr. Sharma to tell us about her very exciting research in the field of cancer immunology, I just wanted to briefly highlight a few of her many, many accomplishments. So Dr. Sharma is a medical oncologist with expertise in genitourinary medical oncology. She's currently a professor of GU Medical Oncology and Immunology in the Division of Cancer Medicine, University of Texas MD Anderson Cancer Center, inaugural scientific director of the immunotherapy platform and co-director of Parker Institute for Cancer Immunotherapy at MD Anderson Cancer Center. She's also a member of the American Society for Clinical Investigation, has received several awards for her contributions, some of which being the Emil Frey III Award for Excellence in Translational Research, the Coley Award for Distinguished Research for Tumor Immunology, and has been honored with the Women in Science and Excellence Award. With respect to publications, she has published close to 150 papers in very highly respected journals, including Nature, Science, Cell, PNAS, Clinical Cancer Research, JITC, and several others. Dr. Sharma, it's indeed a privilege to have you here with us today, and we all are looking forward to hear more about cancer immunology research at your center. So I'm now going to pass it on to Dr. Sharma.
Thank you so much for that wonderful introduction. I'm thrilled to be here virtually, if not in person. I'm going to share the screen and slide presentation mode. Great. So these are my disclosures listed here. And my talk today is really going to focus about how we move between the clinic and the laboratory in order to investigate mechanisms of response and resistance to immune checkpoint therapy. So just to briefly review so that everyone's sort of on the same page in the setting of immune checkpoint therapy, what we know is that the immune system is very tightly regulated. There are on signals that then drive the off signals. So this is very much like this yin and the yang. So if you move the immune system in one direction, there will be something that will then try to move it back towards homeostasis. And actually the first example of this was really elucidated when CTLA-4 was identified, because prior to CTLA-4, there really was no understanding about inhibitory pathways that control T-cell responses. So here you can see in this cartoon that T-cells require two signals, the T-cell receptor interacting with MHC and antigen, and CD28 interacting with B7 in order to be the on signal or the co-stimulatory signals that then drive T-cell responses. But these same two signals that turn the T-cell on are exactly the same two signals that also lead to upregulation of CTLA-4. And CTLA-4 is the inhibitory molecule that outcompetes CD28 for binding to B7 and then turns the T-cell response off. So this is a temporally regulated immune response. And Jim Allison, of course, he's the one who identified the protein structure of the T-cell receptor and identified that CD28 is a co-stimulatory molecule, and then identified that CTLA-4 was a critical inhibitory pathway that controls the T-cell responses. So he proposed that blockade of CTLA-4 with an antibody would then give T-cells sufficient amount of time to then eradicate every tumor cell in a cancer setting. And so this anti-CTLA-4 antibody was then the beginning of the immune checkpoint therapy field, and it's clearly opened up an entire new field at this point. But really, it was this first setting that Jim showed in preclinical models could lead to tumor eradication. And of course, this, as I mentioned, opened this entire new field. And this cartoon here just shows some of the other pathways that are being investigated. Of course, this cartoon is a bit outdated, but it does have the CTLA-4 pathway, as well as the other pathways, including PD-1 and PD-L1 is highlighted here as other approved therapies. So just again, to highlight how dynamic the immune response is, if we were to look at this cartoon here, you can see that in this setting where T cells may be present within a tumor microenvironment, at this particular point, if a biopsy was taken of this tumor, you would not notice any PD-1 or PD-L1 expression because the T cells are not activated as of yet. And so if you get T cell activation, then you will see that the T cells not only upregulate CTLA-4, as I previously mentioned, but they also upregulate PD-1. And the activated T cells will make lots of interferon gamma, and interferon gamma will then lead to upregulation of PD-L1. And it's at this time point then that you can see a biopsy which show PD-L1 positive tumor cells. And I'm only highlighting this again because throughout the talk, I want us to keep thinking about how dynamic the immune response is, and how can we really try to understand at which point do we give which drug so as to target which specific pathway. These are questions that we're still trying to answer. So in the field of immune checkpoint therapy, there have been many, many approvals in the last 10 years, and it's now been 10 years since the field started. But we're really still at the tip of the iceberg in getting many of these therapies into patients. As you can see here, there are multiple tumor types where we've had either an anti-CTLA-4 or an anti-PD-1 or PD-L1 antibody, or even the combination of the two together that have been approved. And there have even been approval now for just having specific mutations or tumor mutation load, as I should mention here, as well as microsatellite instability. So not even the tumor types anymore, but more related to the genomic changes in the tumor that lead to then antigen presentation for T cell recognition. So the key research questions that remain: why do some patients respond and others do not? Can we identify biomarkers that predict response or immune-related toxicities, because these agents are so different from the other agents we've used to treat patients with before? I won't have time to talk about the immune-related toxicities work that we've been doing, but we can have that discussion in the Q&A period. Are there biomarkers to enable patient selection for treatment monotherapy, which has fewer toxicities, versus combination therapy, which has higher frequency of toxicities? Can we increase the number of patients who respond? And are there other pathways that can be targeted to improve clinical outcomes? So I'm going to try and go through how we attempt to answer these questions. Certainly, they're not all answered, and there's much more work that needs to be done. For us to really think about the questions, we really need to integrate the laboratory and clinical research in a very fast manner so that you can move back and forth quickly. We call this reverse translation because of the way that we do this. We start from the patients. Most of you may be aware that in a laboratory, we start with mice, where the mice are inbred and the disease is homogeneous. You can knock in a pathway or knock out a pathway and understand the mechanism very quickly. However, patients are polymorphic and the disease is heterogeneous. And at this time, we're dealing with greater than 2,000 clinical trials. So really, the clinical side is outstripping the basic laboratory side in terms of pace. And so we have a lot of data from the clinic, and hopefully we can use these data then to generate hypotheses. And then we can take these hypotheses back to the laboratory and then design the appropriate mouse model or other preclinical model to test the hypothesis. And then that would give us some data that we can then bring back to the clinic. So this is an iterative process that we keep going, and we've been doing it for quite some time now. In order to make this model work, we do have to rethink clinical trial design so that we can obtain the appropriate samples from the patients for laboratory studies. And you may be aware that phase 1 studies are safety dose escalation studies, and phase 2 are efficacy, and phase 3 are comparison to standard of care. So these are the way that drugs go through the approval process, but they don't really give us a lot of access to tumor samples for laboratory studies. So we really propose these pre-surgical or tissue-based trials, which are phase 1A or phase 2A studies, where the trials can then give us access to clinical signals, as well as provide tissue samples for biomarker analyses and mechanistic insights. So I initially started with these trials in 2004, and actually the first trial was conducted in 2006. And the reason for highlighting these dates is really because these trials were conducted prior to any FDA approvals of any of the immune checkpoint therapy agents. So I just wanted to point that out, because it's clear that we can do these, we can perform these studies regardless of the timing of FDA approval, so that we can gain the biological information to help move the targeted agents along. So the first trial is shown here. It's the neoadjuvant trial with anti-CTLA-4. This was a trial that we conducted in 12 patients with localized bladder cancer. And this trial, again, a small trial because we're not really looking for clinical endpoints per se, but a trial that will give us sufficient access to the tumor samples because it's being given to patients who have localized disease and are scheduled for surgery. So in these 12 patients, they were given 2 doses of anti-CTLA-4 antibody, and then they were taken to surgery. The trial allowed us to have a clinical signal for safety because this was the first immune checkpoint therapy trial where the agents were given prior to surgery in the neoadjuvant setting. And the safety data allowed us to then design multiple other neoadjuvant trials with immune checkpoint agents. It was also a trial for the first trial in patients with bladder cancer, so it gave us a clinical signal for efficacy since we saw that 3 patients developed pathologic complete responses, meaning that their bladder cancers completely went away. And so we knew then that we could take immune checkpoint therapy into the setting of patients with bladder cancer, which is what we did, and led to FDA approval eventually. More importantly, the trial gave us access to the tumor tissues as shown here, and we were able to then compare pre and post-treatment samples to understand the impact of anti-CTLA-4 on the tumor microenvironment. And you can see here that this really, the treatment really led to an increase in infiltrating T cells within the tumor tissues. There's an increase in CD3, CD4, and CD8 T cells as shown here. And these were activated T cells because they were granzyme positive. And also there was an increase in the CD20 positive cells, which are B cells as shown here. What we weren't expecting when we did this differentially expressed gene analysis was this pathway that at the top of this was going to be the ICOS pathway. Of course, all of the top 10 pathways shown are related to signaling within the immune response because we did increase the number of immune cells within the tumor microenvironment. But ICOS was a pathway that was a surprise. And ICOS, just to remind you, is an inducible co-stimulator. It belongs to the CD28 and CTLA-4 family as shown here on this phylogenetic tree. Its expression is increased on activated T cells, including regulatory T cells. And it has a very diverse role that's been reported. And it's mostly associated with follicular helper T cells, which is very interesting because these are the T cells that then help B cells to go through maturation for antibody production. However, a role in anti-tumor responses had not been established. And so when we went back to the tumor tissues, we wanted to know if the gene expression data was accurate in terms of protein expression. And in this flow cytometry plot, you can see, because we had access to the T cells from the tumors, in the non-malignant tissues, the ICOS positive expression was about 13% on CD4 T cells. And in untreated tumor tissues, again, it was about 16%. However, after treatment with anti-CTLA-4, there was a significant increase in this ICOS positive subset. We wanted to then know whether or not these ICOS positive cells were effector T cells, since again, ICOS has been associated with multiple different subsets of T cells, including regulatory T cells. And so we harvested the T cells from the tumor tissues, and then in vitro assays, we asked whether or not these T cells were able to recognize tumor antigens, such as the NY-ESO-1 antigen as shown here that was expressed on the tumor tissues. And you can see that these T cells produced interferon gamma in this ELISpot assay, as well as TNF alpha and MIP1 beta as a result of stimulation with the NY-ESO-1 peptides, indicating that these were effector T cells. Also, in a study that was being conducted by Jed Wolchuk in patients with metastatic melanoma, we had access to blood samples where we can ask whether or not the increase in ICOS positive T cells in the peripheral blood correlated with survival for these patients. And you can see that patients who had high levels of ICOS positive T cells had much better survival compared to patients who did not have an increase in these ICOS positive subsets. In another clinical trial that we conducted in a neoadjuvant setting, and this paper was published last year, we did a combination study with anti-CTLA-4, which was tremelimumab this time, and anti-PD-L1, which was durvalumab. And again, this was in patients with localized bladder cancer, but I need to point out that these patients are high-risk patients who cannot receive cisplatin chemotherapy in the neoadjuvant setting, and so they do not have a standard of care treatment due to their cisplatin ineligibility. So here we took 28 patients and gave them treatment with the combination therapy. And you can see that for these patients who do not have a standard of care and have very high risk of recurrence of disease due to the fact that they are not eligible for neoadjuvant chemotherapy, with this neoadjuvant immunotherapy regimen, we saw 37.5% of these patients had pathologic complete response, again, meaning that the disease went away completely. Even in patients with large disease, 3D mass CT4A disease, we had 12 patients like that. And these patients also had pathologic complete responses of 42% of these patients. So again, we're hoping to move this forward as a novel combination therapy as standard of care for patients who are ineligible for chemotherapy. But again, importantly, from this clinical trial, we had access to the tumor tissues, and we can once again ask what was the impact of the combination therapy in the tumor microenvironment, and what were the biomarkers of response. And in this setting, what we found was that there were tertiary lymphoid structures where you can see T and B cells interacting within the structure, as well as dendritic cells, as shown here. And it is these tertiary lymphoid structures that we found that were higher in the responder patients as compared to the non-responder patients. And again, these were associated with these ICOS positive CD4 T cells within the tumor tissues, helping to form these tertiary lymphoid structures. So now we had these hypotheses that were generated from the clinical data. The first hypothesis was that the ICOS ligand pathway is necessary for effective anti-tumor immune responses in the setting of anti-CTLA-4 therapy. And so to test this pathway, we went back to the laboratory and we conducted studies in wild-type mice, as well as in ICOS knockout mice and ICOS ligand knockout mice. And you can see that in wild-type mice, anti-CTLA-4 leads to tumor regression and long-term survival of these mice. Meanwhile, in the ICOS knockout and the ICOS ligand knockout mice, we have impaired tumor rejection and survival due to lack of the pathway. The second question we asked at this point was, why is the ICOS ligand pathway necessary for optimal anti-tumor responses? And so, as I mentioned, ICOS is part of the CD28 and CTLA-4 family. And so we proposed this hypothesis is that ICOS can induce signaling via the PI3 kinase to promote T-bet expression with subsequent Th1 responses in tumor rejection. And T-bet is a transcription factor that's very important for driving the Th1 responses in T cells. And you can see here that all of these family members, CD28, CTLA-4, and ICOS, they all have this PI3 kinase binding domain within the cytoplasmic tail to enable signaling through PI3 kinase. So to test this hypothesis, we once again went back to the mouse models, and we could take the CD4 T cells from wild-type mice and ICOS knockout mice as shown here. And in untreated mice, the T-bet is not expressed in these T cells. But after treatment with anti-CTLA-4, you can see that the CD4 T cells from wild-type mice increase T-bet expression, but the ICOS knockout mice is not really able to increase the T-bet expression in either the CD4 from spleen, tumor draining lymph nodes, or the tumor infiltrating lymphocytes. And so this impaired expression of T-bet could also impair the Th1 responses from the CD4 cells. But this did not answer the question as to whether or not the PI3 kinase domain of ICOS is enabling the signaling. And so we went to the ICOS YF mice to do these experiments. And the YF mice have a single amino acid change from Y to F in the PI3 kinase domain. And so it abrogates PI3 kinase signaling, but it still has ICOS expression. And because of the ICOS expression now, we can segregate the ICOS positive and ICOS negative cells from wild-type mice, as well as from ICOS YF mice, and ask whether or not T-bet is expressed after anti-CTLA-4 treatment in these mice. And you can see that none of the T cells from the ICOS YF mice are capable of expressing T-bet in the same way as the wild-type mice. And I should point out that all of these T cells have CD28 expression, since many people are aware that CD28 during the initial stages of T cell stimulation or activation, CD28 is what regulates T-bet expression. However, later in the immune response, it seems that ICOS takes over T-bet expression. And so lack of ICOS really impairs Th1 responses. The third hypothesis that we had was that the ICOS ligand pathway can be targeted and developed as a combination therapy strategy with anti-CTLA-4 to improve anti-tumor responses. And so here in one experiment that we did, we did these experiments in collaboration with Jim Allison's group, we were able to show that you could target ICOS plus anti-CTLA-4. And when this was done in wild type mice, you can see in the blue dotted line, there was a significant improvement in the tumor rejection and long-term survival of these mice. However, in the ICOS knockout mice, you lost this ability. And so clearly ICOS is playing an important role in helping with the anti-tumor responses. And so ICOS is now being developed by multiple groups to look at whether or not you could target the ICOS pathway either as antibodies or bispecifics to improve responses with immune checkpoint therapy. So now I just want to switch gears a little bit because I've been talking about melanoma and bladder cancer and other tumor types, which you know as hot tumors, or tumors that have lots of mutations as shown here on this diagram. So these tumors, the melanoma, lung cancer, bladder cancer, they all have many, many mutations, and they've had many approvals with immune checkpoint therapy agents because it is thought that these tumors with high mutations have lots of antigens that allow for T cells to infiltrate. And so these are hot tumors that respond to immune checkpoint therapy. Whereas the cold tumors such as prostate cancer, glioblastoma, pancreatic cancer have many fewer mutations actually. And because of the fewer mutations, it's thought that T cells do not infiltrate. And so these are cold tumors that cannot respond to immune checkpoint therapy. And so as a clinician, I absolutely agree that prostate cancer is a cold tumor. We've had 3 different failed phase 3 clinical trials in prostate cancer showing that immune checkpoint therapy did not work. However, as an immunologist, it's difficult to understand that prostate cancer cannot be recognized by T cells because prostate cancer is still a tumor. It still has some mutations. And T cells do not require hundreds of mutations before they have a response. They only require 1. So we wanted to ask the question whether or not prostate cancer antigens can be recognized by the T cells within patients who have prostate cancer. And so we conducted this clinical trial that we published last year. And here we had 30 patients with metastatic castration-resistant prostate cancer. We can resect the prostate tumor and perform exome and RNA sequencing to identify the tumor mutations. We then treated the patients with anti-CTLA-4 or ipilimumab as shown here. And then we collected the blood samples from these patients and asked whether or not the T cells could recognize these tumor mutations. And so the paper was published with all the details, but I'm showing here one patient, patient number 7. And in this patient, you see the patient had 2 different mutations, one in rogue guanine nucleotide exchange factor 37 and one in dihydropyrimidase. These were single amino acid mutations as shown here. And then when we took the T cells from patients prior to treatment with anti-CTLA-4, the T cells could not recognize either the wild type or the mutated antigen. However, after treatment with anti-CTLA-4 at the post-IPI1, post-IPI2, and post-IPI4 time points, now you can see that these T cells really are recognizing the mutated antigen and producing interferon gamma in this ELISpot assay, but they're not recognizing the wild type antigen. And the same thing for both the rogue guanine nucleotide exchange factor 37 antigen and the dihydropyrimidase antigen. And of course, these assays were done with a positive and negative control as shown here. So since we now know that the mutations in prostate cancers can be recognized by the T cells, the question is, are the T cells infiltrating into the prostate tumors? Maybe that's why prostate cancer is not being responsive to immune checkpoint therapy, because the T cells are not getting into the prostate tumors themselves. And so to ask that question, we had another trial that was ongoing. This is a clinical trial that we did in 20 patients with localized prostate cancer. And these patients were all scheduled for surgery. So we gave them 2 doses of anti-CTLA-4 and had access to the entire prostate tumor at the time of surgery to ask whether or not the T cells were infiltrating into the prostate tumor. And here you can see the prostate cancer really is a cold tumor. Prior to treatment with anti-CTLA-4, there are very few infiltrating immune cells as shown here. However, after treatment with anti-CTLA-4, now you can see an increase in the CD4, CD8, FOXP3, CD45RO, ICOS, granzyme B, and CD68, multiple different immune cells infiltrating. And so we did convert the cold tumor into a hot tumor. But as immunologists, we should have been prepared for the fact that when you drive the T cell responses in one direction, there will be mechanisms that try to control that response. And so because the immune response is dynamic, we do find compensatory inhibitory pathways that are increased, including PD-L1 and VISTA, as shown in this gene expression study. And so when we went back to looking by IHC to confirm the gene expression data with protein expression, you can see that prior to treatment with anti-CTLA-4, there is no PD-1 expression or PD-L1 expression or VISTA expression in the prostate tumors. However, after treatment with anti-CTLA-4, now you can see that there's PD-1 expressed on the immune cells, there's PD-L1 expressed on immune cells and tumor cells, and there's VISTA expression on immune cells as well. And I should point out that VISTA is a novel immune checkpoint that was identified by Randy Noel's group. When we asked where was the PD-L1 being expressed in the prostate tumor after treatment, you can see in this chart here that the black triangles represent the pre-treatment samples and the red dots represent the post-treatment samples. The PD-L1 is predominantly expressed on the T cells, CD8 T cells, as well as macrophages, CD68 macrophages, and tumor cells. And VISTA, which is expressed on CD4 and CD8 T cells as well, is predominantly expressed and really at high frequency on the CD68 macrophages. And so we wanted to look at whether or not the treatment with anti-CTLA-4 in melanoma leads to the same changes, because we know that melanoma responds very well to anti-CTLA-4, whereas prostate cancer does not. And when we compared the melanoma post-treatment tumor tissues to the prostate post-treatment tumor tissues, you can see that melanoma samples had these M1 genes indicating M1 macrophages, which helped in tumor rejection. Whereas prostate cancer really had an M2 gene signature, which means that these myeloid cells and macrophages are suppressing the immune response. And we're still trying to identify the signaling pathways that lead to the macrophages and myeloid cells being M2 in prostate cancer as opposed to M1 in melanoma. But we do know that VISTA and PD-L1 are potent inhibitors of human T cell responses, as shown here. When we incubated the human T cells from these patients in an in vitro assay whereby CD3 was then used, coated on the plate to stimulate the T cells, you can see that these T cells are quite capable of producing interferon gamma and TNF alpha. But when we have now PD-L1 Ig or VISTA Ig, or the two together coated on the plate, now you can see that there's a decrease in the interferon gamma and TNF alpha. So what we did was we proposed a new clinical trial to block both CTLA-4 and PD-1 in patients with metastatic castration-resistant prostate cancer. And we also published this study last year. And here we had 90 patients that received the combination therapy. And you can see with this PSA diagram that there was a decrease, substantial decrease in some patients of PSA, as well as eradication of tumors. But I should point out that although we were now seeing significant anti-tumor responses, we were also seeing an increase in toxicities due to the combination therapy. So this clinical trial was recently expanded to a larger cohort to look at different doses and schedules of the combination to try and minimize the toxicity but maintain efficacy. What we did notice on the clinical trial was that patients with soft tissue metastases were responding very well, whereas patients with bone metastases were not. And as you may know, patients who have metastatic prostate cancer predominantly have bone metastases. And so we wanted to understand what were the differences in the immune response in the soft tissue metastases versus the bone metastases. And so we had access again to the tumor tissues, and here you can see the soft tissue metastases compared to bone metastases from the patients. And what we noticed was that in the soft tissue metastases, after treatment with combination therapy, you had a significant increase in this Th1 response, which I mentioned previously was important for tumor rejection, without much of an increase in Th17 or Tregs. The Th1 response was really driving the response in the soft tissue metastases. However, in the bone metastases, as you can see with each of these diagrams representing a different patient, you can now see that each patient here on the bone metastases did not have an increase in Th1, but now they had an increase in Th17. And so it was confusing why the T cells that were going into the bone microenvironment was skewing towards Th17 rather than Th1. And so we wanted to ask whether or not we can understand this better through a specific mechanism. And so we went back to the laboratory and we set up a mouse model whereby we used castration-resistant prostate cancer and injected those cells into the subcutaneous regions to mimic soft tissue metastases, or we injected the cells into the bone to mimic bone metastases. And then we treated the mice with anti-CTLA-4 and anti-PD-1, similar to in the clinical trial. And you can see, similar to the patient data, now in the bone regions, we were not getting an increase in the Th1 cells. We were actually getting an increase in Th17, which was very similar to the human data. And in the soft tissue, we had a significant increase in the Th1 response and no increase, actually a decrease in Th17 because you're skewing towards Th1, and so you're not developing the Th17 subset. So why might this be happening? Why would we be skewing towards Th17 in the bone rather than Th1? And for those of you who know about the Th17 subsets, they require multiple signals for their development. And so two important signals for Th17 development are IL-6 and TGF-beta. And this paper was published in 2019, and we showed that we did the analysis for multiple different cytokines, but I'm just highlighting these two here. And you can see that IL-6 is rather high in the bone microenvironment compared to serum, regardless of whether there's a tumor. So BM is without the tumor and BMT is with the tumor. And you can see that IL-6 levels are high in both settings. However, TGF-beta is only high when the tumor is present. And we showed in the manuscript that this is due to osteoclast activity. And so now we propose that we would need to block TGF-beta in combination with immune checkpoint therapy in order to appropriately treat the bone lesions. And here in the green boxes, you can see that when we gave this combination strategy, now we had decreased tumor volume in the bones and we had long-term survival of the mice. More importantly, within the bone microenvironment, what we found was that we had an expansion of these Th1 CD4 cells for the first time, as well as expansion of CD8 T cell clones within the bone microenvironment. And so now we are proposing a novel combination clinical trial in patients with bone metastases that will include blocking TGF-beta as well as immune checkpoint therapy. But the data set that we had from that bone microenvironment really made us realize that there are unique subsets that develop within specific organ niches. And so how can we look for these unique subsets to really understand what kind of therapies need to be developed? And so in this setting, we took that idea and we went to a glioblastoma setting. And here we had samples from GBM patients that were untreated, as well as anti-PD-1 treated patients. And we compared the GBM samples to multiple other tumor types: non-small cell lung cancer, renal cell carcinoma, colorectal cancer, and prostate cancer, to try and see what were the unique subsets that just existed within GBM. And what we identified was this L8 subset by CyTOF analysis, and this was a CD73 high subset that seemed to really be unique to the GBM microenvironment. And this subset persisted regardless of anti-PD-1 treatment. And so we knew that this was a subset that would then require targeting of the CD73 pathway. When we looked at the CD73 subset by single-cell RNA sequencing, we found that this subset had a macrophage signature, was very immunosuppressive, and also had a hypoxia signature associated with it. And so in a murine model, we used the wild-type mice as well as CD73 knockout mice. And now we implanted the glioblastoma cells into the brains, and we treated with anti-PD-1 and anti-CTLA-4. And you can see that it is only when we treated the CD73 knockout mice with the anti-PD-1 and anti-CTLA-4 that we were able to have long-term survival of 50% of these mice. And so now we propose a new trial to target CD73, and hopefully I can present data from that at another time. I do want to switch gears a little bit to talk about other pathways that need to be targeted, because again, reminding you of the yin and the yang of the immune response, epigenetic pathways play a very important role in controlling immune responses. As I mentioned before, CD28 and T cell receptor signaling are important for activation of T cells, but they also increase expression of EZH2. And EZH2 is very important for leading to FOXP3 stabilization. And FOXP3 is the transcription factor that is necessary for regulatory T cells that then suppress the immune response. And in our patients who we treated with anti-CTLA-4, we saw that in patients who did not respond, there was an increase in EZH2 expression in these CD4 T cells. And so we wanted to understand whether or not we could block EZH2 and then change these T cells so that they were more effector-like rather than Tregs. And so to do this, we used a FOXP3 GFP mice whereby we can sort the FOXP3 positive cells through GFP expression. And then we can incubate these cells with or without an EZH2 inhibitor and ask what happens to the cells from a phenotypic as well as functional standpoint. And what we saw phenotypically was that we were able to decrease expression of FOXP3 and increase expression of interferon gamma related genes such as CXCL10, granzyme B, and interferon gamma. So switching them now to more of an effector-like T cell. And when we looked at this functionally, we could see that without the EZH2 inhibitor, these cells are quite capable of suppressing effector T cells as shown in the CFSC dilution analysis. However, in the setting of an EZH2 inhibitor, now they're no longer able to suppress the effector T cells. And so we proposed a combination trial whereby we can have anti-CTLA-4 with EZH2 inhibitor. And this is the preclinical mouse study showing that when these two were given together, we had tumor regression as well as long-term survival with improvement due to the combination. And so this clinical trial is now ongoing, whereby we have an EZH2 inhibitor in combination with anti-CTLA-4. And this is being given to patients with metastatic prostate cancer, bladder cancer, and kidney cancer, including patients who failed anti-PD-1 therapy. We have 7 patients treated to date, and the trial is ongoing. So again, hopefully I can give an update at a later time as to the data from this study. I do want to touch also a bit on tumor cell intrinsic resistance mechanisms, because I've talked a lot about how the immune response controls itself. And so a lot of the things I've mentioned are immune cell pathways that are resistance mechanisms. But the tumor cells themselves can also have mutations within the tumor cells that lead to resistance. And so in one study that we published, we were able to show that patients with melanoma who did not respond to anti-CTLA-4 had copy number alterations in the interferon pathway genes. And so you can see that the patients who now have these copy number alterations, when we looked at their cells, they're not able to respond in vitro to interferon gamma. And then when we were able to, when we were able to look at the cells, we were able to find that really these interferon gamma genes were never upregulated because the pathways that were involved in terms of interferon signaling led to JAK-STAT dysfunction. So this is another way now to think about how to look at the tumor cells themselves for what mutations may be leading to failure of interferon gamma to then have a response. So even though the T cells are making the interferon gamma, the tumor cells themselves cannot respond. And then finally, how do we integrate all of these data sets? How do we integrate tumor cell pathways and immune cell pathways so that we can select the right patients for immune checkpoint therapy? We did this in a retrospective analysis whereby we were able to then take our data sets that we had from both preclinical models and human data. One of those data sets indicated that if we were to use tumor cells that were mutated in ARID1A, mice were able to reject the ARID1A mutated tumor cells much better than wild type tumor cells. And again, in studies in CXCL13 knockout mice, we were able to show that if CXCL13 is lost, we then lost response to immune checkpoint therapy. So we took these different data sets and we integrated them to then ask whether or not patients who had both an ARID1A mutation and CXCL13 overexpression had much better survival compared to patients who had either one or the other or neither of the above. And what you can see in the studies that we used, which were the metastatic bladder cancer studies from Checkmate 275 as well as IMvigor 210, that in both of these large studies, if a patient had ARID1A mutation as well as overexpression of CXCL13, patients had much, much higher survival in these two studies. And this is in a retrospective analysis. To prospectively test this now, we've proposed a clinical trial whereby we'll have two cohorts of patients. Patients with unresectable bladder cancer who are documented to have an ARID1A mutation. And then patients in cohort 2 will have any tumor type with an ARID1A mutation. And these patients will then receive anti-PD-1. And we will then look at their responses based on whether or not the tumors have high CXCL13 expression or low CXCL13 expression. And these will be our co-primary endpoints of overall response and survival. The other thing is that because CXCL13 is being engaged by nanostring analysis, we can then use this to confirm an IHC assay, whereby we can then develop a CLIA certified IHC assay and then use that in a future trial with the CLIA certification of the IHC assay as well as the ARID1A mutation, to use them both at the same time to select patients for treatment with anti-PD-1. So again, as I mentioned, there are multiple different pathways that need to be taken into consideration as we look at the field of immune checkpoint therapy. I only mentioned a few today, CTLA-4, PD-1, VISTA, ICOS, but there are many more, including LAG-3 and TIGIT, for which we've recently seen positive data in combination with anti-PD-1. So we're just at the tip of the iceberg in understanding how all of these pathways are acting and at which time points are they acting and in which specific organ niches may they have prominent roles. So for us to really continue to do this work, we have to set up systems whereby we can integrate the clinical trials with the laboratory. And at MD Anderson, we did this through the immunotherapy platform. As of May 2021, we have greater than 100 trials, actually 113 trials across 18 departments. And they all are allowed to then provide samples from these studies under one umbrella lab protocol, which is the PA13 protocol. And it enables collection of samples from all patients so that we can perform the immune monitoring that's necessary to understand how these agents are impacting the tumor microenvironment and how the immune response is changing as a result of these treatments. So we have greater than 4,000 patients that have been enrolled with longitudinal samples collected from a lot of these patients and analyzing the data, hopefully for large set data set integration. So I'll just conclude by saying immune checkpoint therapy has certainly joined the ranks of surgery, radiation, and chemotherapy as a pillar of cancer treatment, and combination strategies are clearly the future. However, which combinations and when to use them are important questions to ask, since multiple immune checkpoints exist and they're very dynamic in their expression. And we're going to need to evaluate both pre and on treatment human tumor samples to guide therapeutic decisions. And the organ-specific microenvironment will need to be considered in order to understand immunologic subsets and subsequent immune responses against the cancer cells in these organs. And hopefully I've shown you that pre-surgical and tissue-based clinical trials really do provide a feasible platform to study the biologic effects in patients, which then provide insights into mechanisms that can be targeted for rational combination therapies. So I have many, many people to thank. Their names are all listed here. I do want to highlight JJ Gao, who did a lot of the work in the original clinical trials and now has his own lab. And Sangeeta Goswami also did a lot of the work that I recently mentioned and now in her own lab as well. I do want to thank the many people in geomedical oncology, urology, and pathology who continue to work with me on these studies, as well as the immunology and immunotherapy platform team, the many, many protocol data managers and research nurses that are involved, and of course the patients. Some of these patients, as you know, and as you can see from the talk, are patients who were scheduled for surgery and really have no reason to be undergoing a clinical trial, but they still participate so that we can learn from them, and I'm very grateful for that. So I'll stop there and I'll take questions. And I left enough time for questions, I hope. So thank you.
Thank you, Dr. Sharma. That was one fantastic talk and a great summary of what all is ongoing with immune checkpoint blockade therapies. A beautiful update. And very fascinating, obviously. I've got a lot of questions, but I really want to open the floor for trainees here first in the audience. If there are any trainees and have questions, please go ahead.